I am an intensivist. I work in one of the hospital environments where there is mostly technology and high-tech treatments. That's how people usually think about intensive care. But intensive care units are mainly about people. The relationship between all these people in the ICU are so important. The dynamics of the team, but more importantly, the relationship that we build with the patient and the family.
Sono rimasto particolarmente colpito dal pronto intervento ogni volta che avevo necessità, sia a livello fisico che psicologico. Il personale interveniva sempre con molta affabilità, quindi molto gentilmente. Mi sentivo veramente accudito e protetto in ogni momento della giornata. Quindi da questo punto di vista sono rimasto molto soddisfatto. Venivo inoltre informato su quegli aspetti clinici che avrei dovuto subire da quel momento in poi, quindi mi veniva spiegato nei dettagli cosa avrebbero fatto e come lo avrebbero fatto. Al momento del risveglio non avevo ovviamente le idee molto chiare, stavo vivendo due realtà diverse, una quella vera in rianimazione e un'altra che era quella degli incubi, per cui il primo periodo non avevo ancora capito bene quale delle due era vera. Solamente dopo aver parlato ripetutamente con i medici che mi rassicuravano e mi spiegavano appunto questo fenomeno degli incubi e soprattutto anche dopo aver parlato con mia moglie al telefono, ho capito qual era la vera realtà. Le due realtà erano vissute ambedue dentro il reparto, quindi per me era difficile distinguere. L'ingresso di mia moglie in terapia intensiva è stata una inaspettata e piacevole sorpresa. Non ricordo molto di quel momento, le parole soprattutto, però ricordo benissimo le sensazioni e lo sguardo di mia moglie. La terapia intensiva è un'esperienza sicuramente molto dura. Viene vissuta probabilmente in modo diverso da ognuno di noi in base al proprio carattere. Il messaggio che posso mandare è un messaggio di fiducia e di speranza, in quanto dobbiamo totalmente metterci nelle mani del personale sanitario che ha la formazione corretta per gestire soprattutto gli aspetti, oltre che quelli clinici, anche gli aspetti emotivi della persona e quindi psicologici, che sono, secondo me, forse per il paziente e la famiglia, gli aspetti più importanti.
You are the spouse, you are the brother, the sister, the parents, the children of an ICU patient, you are a friend. All of you are family members. Of course, we are not going to have the same communication with any of you according to what's the relationship between you and the patient, but we are concerned by how you are doing, whoever you are, and whatever is your relation with the patient.
The team was so human and kind. They helped me psychologically every day. I was waiting for the call every day with impatient. So that period was really very hard for my family. The team of ICU became really my family. I felt them closer even than my parents. Every day someone from the team called me and informed me about the situation of my husband and the next steps to do. And I want to say that even if I was far from my husband, I have been always updated about his clinical situation. And when there were very important decisions to make, for example, like tracheotomy, they called me 4-5 times per day. So I want to say thank you. For me, it was a new experience, like for many other people. I have never faced ICU. So after this experience, I changed my life. I changed all points of view. It was a really very hard period, and I was about to lose my husband, but I have never lost hope, and I tried to be strong and rational. I remember my first visit in ICU very well, because it's impossible to forget. It was so emotional. After 64 days, finally, I could see my husband, touch his hands, see his eyes. It was really very difficult to live without him and without personal contact. I don't have enough words to say thank you to the doctors for that possibility that they permitted me to visit him in ICU. Thank you very much. I'd like to say to the future patients and their families that they should trust to the staff of ICU. They're left in the hands of professionals that work tirelessly with passion and love. They are always with the patients. The patients are the primary focus for them. They always gave the warm care and necessary treatment. They never leave alone patients. They are always with them and ready to help them in any moment. The patients are the primary focus for the staff. At the end, I want to say, no matter how ill is the patient, don't give up hope.
Having a loved one in the ICU can be an extremely distressing experience. Some family members suffer from symptoms of anxiety, of depression, some feel lost or even disorientated. So don't forget to take care of yourself. Sometimes you will need to take a break. You don't have to stay with the patient 24 hours a day, and you mustn't feel guilty if you do need to take that break. Don't forget that the ICU team will continue to care for the patient while you're not there, and they will always call you if there is a change in his or her condition.
My name is Silvia. I'm a critical care nurse. I work in an intensive care unit. My work is to assist the doctor and to help them to prepare the patient to get all the medicines and the treatments they need in the ICU. When the family first enters in the intensive care unit, I will receive them and welcome them and present them the room and the patient and explain the condition of the relative. I will be there to receive also their emotions, how they are feeling about it, and explain them what the patient is feeling at the moment, what we are going to give them for treatment. We will be there in any case to help them to go through these days in the intensive care unit and to perceive and communicate with the patient. We will be there to help him and assist him to the toilet, to the feeding, and to do anything that the patient will not be able to do. But moreover, we also will be there to see how is he feeling, if it's uncomfortable, if it's in pain, to learn to communicate with him all over the stay with all the equipment he will have. We will explain them the things that will happen to him and to his family, and to interact between the doctors and the patient.
The main role of a physiotherapist is the rehabilitation of the patient. With the term rehabilitation, we mean restore the previous situation that the patient had before his or her injury, his or her trauma. And so the patient could have again his or her previously autonomy in the best way it could be possible. A physiotherapist could work inside the intensive care unit, so it is a member of ICU team for all his or her working time, while in other countries the physiotherapist comes to ICU just only for the rehabilitation moment.
Hello, my name is Stefan Schaller. I'm an anesthesiologist and intensivist. As a medical doctor at the ICU, I'm part of the healthcare team taking care for patients. My role is to coordinate the healthcare team to do the diagnosis and the treatment of the patient. To you, as a family members, I have to explain what is going on with your family member in the ICU. I explain to you what we are doing for diagnosis. I tell you the options for treatment and how to treat the patient. Very often we have to discuss what are the wishes of your relatives, although he's not responsive. Therefore, we discuss together with you what is the best care we could provide for your relative. In the beginning of your ICU treatment, very commonly you are unresponsive. You will be examined by me or a colleague every day. We will make the diagnosis plan and the treatment plan. Later on, when you're waking up again, we are starting to talk with you about the treatment plan as well. While you are unresponsive, we try to discuss the care with your family, or we look at any documentation you provided, how the care should be provided for you.
As a social worker, I'm part of the ICU team. I regularly come on a daily basis to the ICU and talk with the professionals on issues with the families or with the patient. For example, when it's about communication or when there are conflicts, but also when the families have a request so that I can help them to overcome that issue. What I notice is that the families have a really difficult time. They are stressed about their loved one, but they also have, for example, issues for themselves. For example, they have questions, can I take my children into the ICU? Or how can I manage the homework? Or what can I do about financial problems? So I try to help them with that kind of issues. And sometimes they are also asking life questions, because, for example, why is this happening to me or to us? And what's the meaning of this, that he or she is going to have this critical illness? So I try to help them with this kind of issues. My relationship with the patient is to get him or her to learn him better. And I think it's very important to have the values, what is important for the patient, to have them bring into the care that we provide in the ICU. And I think that it is compassionate care, humanizing care, and that is combined with the highest technical and medical treatment that we provide. And in that way, we have excellent care that we can provide in the ICU. And I try to bring my expertise and to have the patient and his meanings and his opinions in front of it.
A special aspect in my daily practice is the communication with the patient and the communication with the families. Communication in ICU is very difficult because clinical situation is very complex and sometimes it's not so easy to explain to families. And in my opinion, the most important thing is to try to keep it very simple, not to spend a lot of technical words, but I just only try to explain the clinical status with simple words. It's very important to try to develop a relationship with the patient and try to keep it quiet, to tell him that the situation is under control. It's very important to maintain a patient calm and confident with the team, because very often the patients are very scared by the environment of the ICU. So it's very, very important to guarantee the comfort of the patient.
We work together as a single team with patients and families, and that's crucial for the recovery of our ICU patients.
Good afternoon or good morning or maybe good evening, ladies and gentlemen, and welcome to this webinar launched by the Acute Respiratory Failure section of the European Society of Intensive Care Medicine. I'm Claude, an intensivist in Lyon, France, and I'm very happy to serve as a moderator of this webinar entitled Assist Breathing in ARDS Patients. Just a few words to introduce the topic. As clinicians, we are happy when providing our ARDS patients with assist mechanical ventilation. In our mind, the patient is going to get in a better shape. However, this phase is going, this phase is not without risk. And because the lung protective mechanical ventilation should continue to drive our goal, but it may be perhaps more difficult to achieve than in the previous phase, where the mechanical ventilation is fully controlled by the brain of the physician. Indeed, if too high, the ventilatory support may contribute to further injure the lung, and if too low, it may even injure the respiratory muscle. So to deal with these issues and to try to find out the right balance, we have two top speakers for a 20-minute talk each. And you may ask questions during the talks, but the question will be collected through the WhatsApp application, and the question will be discussed after the second talk. So we have 15 minutes for discussion at a 4:45 at the end of the second talk. So I'm very happy to introduce the first speaker. Professor Laurent BROCHARD is very well known. He is the director of the Interdepartmental Division of Critical Care Medicine and a clinical scientist at St. Michael Hospital in Toronto, Canada. He has been editor-in-chief of Intensive Care Medicine Journal, the journal of our society, and is currently the deputy editor of the Blue Journal, the American Journal of Respiratory and Critical Care Medicine. He created the REVA network of research in France and beyond. He is leading the PLUG working group. He has published more than 600 peer-reviewed papers, and his H-index is greater than 100. He's going to talk about the assessment of inspiratory effort and drive during assist ventilation in ARDS. So thank you so much, Laurent, to be here. It's a privilege and a pleasure to have you with us. And the floor is yours.
Thank you very much, Claude, and thank you to the ESICM for organizing this webinar with the acute respiratory failure section. And my first talk is to give an idea of how to assess inspiratory effort and respiratory drive during assisted ventilation in ARDS and the reason why to do it. I've been working with a number of companies to get research grants like Covidien and Draeger and equipment from other companies which are listed here. So this is a complicated slide, but it's two figures from the paper we published after a 3 days conference where we tried to put together the concept briefly mentioned by Claude about having both lung and diaphragm protective ventilation. Indeed, we are all convinced that we need lung protection, but it may be very important to think as soon as possible to also diaphragm protection. And on the left, you have a schema indicating that when you start mechanical ventilation, you think of respiratory homeostasis and gas exchange. You immediately think of lung protection, which is probably in most of the cases the priority. But as soon as possible, you also should ensure diaphragm protection, and this should improve patient outcome. And on the right, you have this complicated schema which indicate all the possibilities in terms of ventilation settings, context, which may act both on the lung to create lung injury or on the diaphragm to create diaphragm dysfunction. And this brings the concept of trying to measure what the patient is doing, both in terms of drive and effort. So we often speak of both respiratory drive and inspiratory effort. And I'd like to very briefly explain why these two concepts are linked, but also different. So again, on the left, you have a schema of the classical way to present respiratory drive, which is the black line saying how the brain responds to change in CO2. really the CO2 in the system is the main driver of the brain response in terms of ventilation. And you see the change in ventilation. And this slope can be changed with acidosis or alkalosis, and of course with sedation, something we do all the time. And where we are on this curve depend on the other curve called the metabolic curve, which tells how much CO2 can be cleared with a certain level of ventilation. And this depends on the efficiency of ventilation, which is expressed by the dead space, and of course of the CO2 production. But on the right, you have another curve which indicates what happens in disease, in patients in the ICU. You still have the ventilation curve, you still have the metabolic curve, but you have another curve, which is the brain curve, which is dissociated from the ventilation curve. And the reason of this dissociation is that what the brain would like to achieve in terms of ventilation may not be possible because the respiratory mechanics is poor, because the muscles are weak, and therefore you may have a dissociation which typically generate dyspnea, but also generate dissociation between the drive, which may be very high, and the effort, which may not always be that high because of the mechanical conditions. So the first thing is about lung protection. And of course, this is, as I said, the priority. So this is, again, a very schematic presentation saying, well, if we think that during controlled mechanical ventilation, the main driver for ventilator-induced lung injury is the distension expressed by the transpulmonary pressure, which is airway minus esophageal pressure. Well, you can imagine that you can achieve exactly the same transpulmonary pressure during spontaneous breathing with this drop in esophageal pressure, and especially during partially assisted ventilation, where both the patient is creating negative pressure and the ventilator is giving positive pressure. So we think that the conditions are there to also have, let's say, ventilation-induced lung injury, not ventilator only, during assisted breathing. And we have very strong experimental evidence for that. This is a nice study by Takeshi Yoshida, where on the left you have the airway pressure, on the right you have the same airway pressure, but with spontaneous ventilation on top of it. When I say on top of it, I mean the negative pressure swings generated here by the animals, are the magnitude of this depression is added to the magnitude of the positive pressure, creating a huge transpulmonary pressure. And interestingly, they showed something which is important for clinical practice, the fact that the result of adding spontaneous ventilation depends very much on the severity of lung injury. If the lung injury is not severe, well, it's good to have spontaneous breathing. You reopen more areas of the lung and you may improve gas exchange. But if the lung injury is severe, you may simply worsen inflammation and regional injury. So for the clinician, difficult to know where is the good limit. And this led to the concept, again, very well demonstrated in animals, but where we don't know exactly where it happens in patients, is this concept of patient self-inflicted lung injury, where the respiratory drive is so much increased that it creates huge swings in transpulmonary pressure, which can decrease the alveolar pressure and generate negative pressure pulmonary edema, but also generate more injury, more capillary leak, and go into a vicious circle. So this is the very simple principle why we need to measure drive and effort for protection of the lung. And as you understood, the drive is very important. But we also want to protect the diaphragm. And this paper described the mechanism of diaphragm muscle injury, which we call myotrauma. And you have schematically three main conditions which can create myotrauma. The first one, very well known now, is over assistance myotrauma, which means the diaphragm and the respiratory muscles are not working enough. And this is when you completely sedate the patients, or even you don't sedate completely, but the patient is doing very little. And it has been called repeatedly ventilator-induced diaphragm dysfunction, VIDD. The second possibility, which happen also under assisted ventilation, is when the patient is under assisted. And excessive loading on the muscle can generate injury and fatigue. And the last condition is when the ventilator and the patient are not working in synchrony. And especially when the effort of the patient occurs during the lung deflation, so causing what's called eccentric myotrauma. So that's the principles, and that's why, again, we should try to understand what the patient is doing. An example of the first circumstance of his diaphragm inactivity is what happens after intubation. This is a series of 70 patients where we measure the activity of the diaphragm just after intubation. And with Michael Sklar, we try to calculate how long it takes for a given patient to resume a minimal level of electrical activity. And on average, it takes 24 hours. But as you can see, in half of the patient, it takes more than that. And for some of them, after 5 days, they still do not have resumed a normal activity. And what was interesting was that the factors explaining the duration of inactivity were sedation and control versus assisted ventilation as expected, but absolutely not severity. There was no relationship with severity, either lung severity or general severity. Strongly suggested that this has something to do with the way we manage the patients, and maybe this is something which may be possible to change. So if we go to the patient at the bedside and try to think how we could make measurements and try to estimate what the patient is doing, we should think of starting from the brain, the respiratory centers. And this is where the respiratory drive starts. So measuring directly the respiratory drive is very difficult, but the first thing which can be done is following what the phrenic nerve is doing and giving to the diaphragm. So this is the electrical activation of the diaphragm, which can be estimated from the electrical activity of the diaphragm. I will mention that very briefly. Then this is transformed into inspiratory effort, and this effort is classically measured by esophageal and gastric pressure swings. When you measure esophageal pressure, you measure the activity of all respiratory muscles. If you measure the difference between esophageal and gastric, you capture the activity of the diaphragm. The diaphragm can also be estimated by other tools like the diaphragm ultrasound, which can estimate the thickening fraction of the diaphragm. And lastly, and I will concentrate on that, this will change induce modification in airway pressure on the ventilator. And we now have non-invasive techniques essentially based on occlusion on the ventilator, like the P01, the POCC, occlusion pressure, or the patient muscular index, PMI, which can be measured by simple occlusion and which can give you numbers as reflect of what the patient is doing. So the classical way, again, to measure effort is to look at the esophageal pressure changes or the transdiaphragmatic pressure and calculate what we call the pressure time product. It's not a simple index to measure because you need to compare these swings to what's happening during a passive breath. Because during a passive breath, the esophageal pressure is not flat, it's going up because of the recoil of the chest wall. So when you get that, you can do these pressure time product measurements, or if you plot the pressure against the volume in a Campbell diagram, you can measure what is called the work of breathing. We tend to prefer the pressure time product because it does not imply a change in volume, so it can measure the effort also during ineffective efforts, for instance. But these, of course, are relatively complicated tools. So if we want to assess it more simply, I mentioned already that we may be able to measure the electrical activity of the diaphragm, which is interesting because it is relatively close to the brain, so it's a good reflection of the drive. The main drawback today is that it's a measurement which is very reliable to compare one situation to another, but we don't know very well how to interpret it in terms of absolute value. So to interpret the numbers and say this is high or low, we don't know how to do it. So what we can do is to use occlusion. And occlusion on a ventilator is done very easily, either automatically, either by a maneuver, either during the trigger phase. So the most useful is probably the inspiratory occlusion because it's available on every ventilator. And you can measure the drop in pressure in the first 100 milliseconds. It's called the pressure at 0.1 second, or P01. Or if you do the occlusion during the whole breath, you can measure the delta pressure called the POCC. On some ventilator, you can also perform an inspiratory occlusion during pressure support ventilation, from which you can measure two things. One is the pressure generated by the muscles, or just the plateau pressure, like during controlled mechanical ventilation. So the P01 is a, let's say, old classical index, and what is new is that it's now available on most modern ICU ventilators. And you have here two examples. You have a complete occlusion, but you don't need the complete occlusion. You just need the first 100 milliseconds. And that would be a patient with high drive, relatively high values, close to 4 centimeters of water, and high effort. And this would be a patient with very low drive, P01 below 1 centimeters of water, and low effort. So you see here a relationship between drive and effort. And you see also that the interest of these indexes is we have values and we can try to interpret these values. So the good news is that most ventilators are quite reliable in terms of the value they display. This is a quite extensive study we did with Irene Tilias, where we looked at many ventilators, and it worked very well in general. You can see on the servo ventilator, it tends to underestimate the value at high drive, but this is because there's no real occlusion when you have a flow triggering system. So if you want to have a reliable value, it's better to switch to a pressure triggering system, and then it will be okay. What's interesting with the P01, it's at the very beginning of the effort. So it's measuring, and that's a bit paradoxical, it's measuring more the drive than the effort. And indeed, the relationship between this drive, P01, and the effort, like the pressure time product, depends very much on the mechanics and the quality and the respiratory function. This is an extreme example where we compared healthy subjects to patients in the ICU. And you see the slope is very different because the healthy subject have much better effort for the same drive than ICU patients. So you cannot expect to measure exactly the inspiratory effort with the P01. You measure something more related for the drive. However, if your P01 is low, you be quite sure that the effort is low. So you see it's a very high accuracy to detect the low effort. And when I mean low effort, it means insufficient to maintain diaphragm muscle activity. It's a little bit less accurate to detect high effort, but if your P01 is close to 4 centimeters of water, you may say, maybe I should look at my patients or maybe do another measurements. And the other measurement you can do is, instead of simply the initial occlusion, which can be done automatically by the vent, doing manually a complete occlusion at the end of expiration. And therefore, the patient will do a full effort, which creates a negative pressure swing. And as you can see here, it exactly reflects the esophageal pressure decay. But as you can see also, it's always higher than the usual effort of the patient during normal breathing. And the reason is that when you occlude at end expiration, the diaphragm is in the best condition to perform negative pressure, so it tends to overestimate the usual PMUS. That's why we recommend to use a formula around this one, like 70% of the POC will give you what is the amount of PMUS exerted by the patient. The last index is the inspiratory occlusion. So like an occlusion during controlled ventilation, but during assisted breathing and during especially pressure support ventilation. So the surprise here, and you need to know that, is that the plateau pressure during inspiratory pressure support, for instance, will be higher than the pressure level. And the reason is that it reflects the negative pressure swings which were generated by the patient. This is why some authors have proposed to measure the difference between the peak pressure and the plateau as an index of the effort generated by the patient. But probably the most interesting in this maneuver is to directly measure the plateau pressure. For instance, if your patient is on the pressure support level, which seems to be safe, but the plateau is in fact higher than 25 or 30 centimeters of water, you may be concerned that this is injurious for the lung. And there are criteria to say that this maneuver is okay. So you see two examples where it doesn't work because it's not stable, and it's probably because of expiratory muscle activity. So it's probably a little bit more complicated, less reliable than the other indexes, and it cannot be measured on every ventilator. Let me finish with two examples how we could use it. I mentioned repeatedly that the interest of having these pressure measurements is that you can have numbers. And we are starting to have more and more values to compare with. For instance, this is the mean value of the muscular pressure when you do a synchronous breath during pressure support. You see around 10 centimeters of water. By contrast, if you have a reverse triggering with breath stacking, you may be around 15 centimeters of water, which is clearly high. At the opposite, if you have an ineffective effort, it's very small efforts, which may be around 5 centimeters of water or less. And I will finish by this very nice study, which was done in COVID-19 patients who had been intubated for hypoxemic respiratory failure and who started to recover. And maybe 1/3 of the patients, after being switched to pressure support, deteriorated and worsened. They call it a relapse. And these patients were monitored by these two indexes, P01 and delta POCC. And really interestingly, you can see that those who relapsed could be detected early on by having high P01, you see 6-8 centimeters of water, or very negative delta POCC like -20 or -30. It's not a direct causal relationship, but at least it tells you something wrong is happening for my patient and probably I need to go back to sedation. So I'll stop there, be happy to answer any question after the second presentation, and please visit our blog, coemv.ca, for continuing this discussion. Thank you very much.
Thank you so much, Laurent, to be right in time. I'm very happy to introduce the second speaker, Martin DRES, who is the Associate Professor in Paris, France. He's an expert in respiratory physiology, and in particular in diaphragm assessment and also in weaning. And he's going to talk about diaphragm function and weaning from mechanical ventilation during ARDS. The floor is yours, Martin, for 20 minutes.
Thank you very much, Claude, and thanks a lot to the ESICM and the Acute Respiratory Failure section for the invitation. I'm really happy to be here and very honored to speak after Laurent BROCHARD, who has been my mentor. So it's really a privilege for me. So now I'm going to discuss diaphragm function and diaphragm dysfunction in particular at the time of weaning from mechanical ventilation in ARDS patients. So I just want to show you my disclosures first on these slides. And maybe to start with, let's say, a simple story of, let's imagine that the story is simple. In the ICU, it has been already discussed before by Laurent BROCHARD. We put our patient under mechanical ventilation, and this is something that is really well established. We put their respiratory muscle at rest, which may induce disuse and an excessive unloading that will induce diaphragm dysfunction. So we have a lot of experimental studies, but we also have some human evidences. For instance, this very important and landmark study by Sanford Levin in 2008, they compared two groups of patients. On the right, a group of patients, the control patients who were exposed to a very short duration of mechanical ventilation. And on the right, a group of patients in the ICU who were brain dead donors and who were exposed to a very longer duration of mechanical ventilation, as you can see, 18 to 79 hours. And the striking result that you can see right now on the screen is that there was an atrophy on the right side. You can see the small side of the respiratory muscle fibers that is really nicely demonstrated on the pictures. So this is really a demonstration of atrophy induced by diaphragm disuse. And more than that, more than atrophy, we also have some evidences of dysfunction. This is here another important study by the group led by Samir Jaber in Montpellier. They evaluated the diaphragm function as its capacity to generate a pressure. So what they did is that they stimulated the diaphragm, they stimulated the phrenic nerves to generate a diaphragm contraction, and they measure the response in terms of pressure, intrathoracic pressure. So as expected, the white bar that represent the healthy, the controlled, shows a normal diaphragm function, about 20 centimeters of water of depression during the stimulation. And the black bars represent the patient in the ICU, day 1, day 2, day 3, and day 5 and 6. And you can see, this is a really a very nice demonstration here of a progressive decline of a time-dependent diaphragm dysfunction. So we have evidences of atrophy, and we also have evidences of dysfunction that is a time-dependent dysfunction. But of course, the story is not simple. So just before, Laurent BROCHARD showed us some discussion about the potential harmful effect of overuse and insufficient unloading on the prevalence and the occurrence of diaphragm dysfunction in the ICU. I'm going to tell you a little bit more about that. This is here a very nice study that has been published in the Blue Journal in 2001. And in this study, again, the investigators obtained a biopsy of the diaphragm in one group of patients. There were patients who had a short duration of thoracic surgery. And before the surgery, some of the patients had a rehabilitation program of inspiratory loading. And what they did is that they looked for a sign of diaphragm injury on the histology exams, and they were looking for sarcomere disruption. And what you can see is that the group of patients who had no loading, no inspiratory loading, had a lower level of diaphragm injury, which is suggesting diaphragm injury may increase with loading, and it is the reason why we could speculate on a load-induced injury directly on the diaphragm. And just to completely discuss this mechanism, I want to show you this study that was performed by Yuan Golliger in Toronto. They enrolled close to 200 patients under mechanical ventilation, and they used diaphragm ultrasound to measure the thickness of the diaphragm. And what they found is that first, and this is something expected, they found that a large majority of the patient had a decrease in the diaphragm thickness. This is what we could call atrophy, 41% of the patient. But they also found that, let's say, 1/3 of the patient had no change in diaphragm thickness. I think this is something that can be understandable because actually it's not that easy to measure the diaphragm thickness. And I think it's really, really logical that in some patients it was not possible to observe a change. But the most striking result is that they observe an increase in diaphragm thickness in 1/4 of the patient. And more importantly, as you can see on the right schema, the panel on the right side, that shows the probability of weaning success depending of the change in diaphragm thickness from baseline. So on the left, you have what is expected, an atrophy, so decrease in diaphragm thickness that is associated with a decreased probability of weaning success. But they also showed that the patient who had an increase in diaphragm thickness had the same bad outcome that could be could be explained by the load-induced injury. So I think it's really an important result that indeed is another break in the wall of the load-induced diaphragm injury or myotrauma. And actually, the story is really complicated. I don't want to go into details here, but just to tell you that beyond the insufficient unloading and the excessive unloading, there are many other risk factors that may lead to diaphragm weakness. So clearly, the story is complicated, but we can keep in mind that when we have our patient under mechanical ventilation, we certainly may have the possibility to influence the insufficient unloading and excessive unloading because we have the control of the inspiratory effort as it has been already discussed before. So now I'm going to explain why diaphragm dysfunction is important in our patient, and in particular at the time of weaning. If you look on this picture, you have the prevalence of diaphragm dysfunction according to several papers that all use the reference technique, that is a magnetic stimulation of the phrenic nerves to evaluate the diaphragm function. And you can see actually that the prevalence of diaphragm dysfunction is very high. It's, let's say, if we want to keep a simple message, it's more than 2/3 of the patient at just upon the admission, but of course during weaning, and of course again in patients with prolonged weaning, we can have up to 80% of the patient that may present a diaphragm dysfunction. So for a long time, it has been the subject of, and it is still the subject of study to evaluate the role of diaphragm function during weaning. I wanted to show you this study. It's an old study published in 1986. And in this study, the investigators wanted to compare the diaphragm function between patients with weaning failure and weaning success. And they use a very interesting index or indice, the transdiaphragmatic pressure, that is the specific contribution of the diaphragm diaphragm during the inspiration. And here you have an index that is a PDI over the PDI max. So it tells you that if it is close to 1, that basically the diaphragm is working on its capacity, the maximal capacity. And what you can see here is that for the patient who had a weaning failure, indeed their diaphragm was working at its maximal capacity. That was not the case of the patient who had a success, because the PDI over the PDI max was much lower. And when you can look also to the gastric pressure, that is also an index of the function of the diaphragm, because when the diaphragm contracts, it goes down, so it will increase the pressure in the abdominal compartment, and we can have an access to this pressure by measuring the gastric pressure with a balloon. And you can see that the patients who were associated with a weaning failure had a weak diaphragm, because the gastric pressure was much lower than the patient who had successful weaning. And ourselves, we also performed and conducted a study in our center, and we also use the phrenic nerve stimulation technique to evaluate the diaphragm function. And we wanted to compare the weaning outcome according to the presence or the lack of diaphragm dysfunction at the time of weaning. And you can see that patients who were associated with a diaphragm dysfunction had a difficult weaning, a prolonged weaning, but more importantly, they also were associated with a higher ICU mortality, but also hospital mortality. So I think it's also important to say that it is not a causative result, it's an association, a relationship between diaphragm dysfunction and outcome, but a lot of study has reported a similar association with the phrenic nerve stimulation or with other tools such as the diaphragm ultrasound. So to just briefly mention the use of diaphragm ultrasound, I wanted to show you this study that we published just a couple of months ago. We performed this study in 2 ICU, in Toronto and in our ICU in Paris, and we enrolled 122 patients. But here we wanted to evaluate the diaphragm function after extubation in patients who had a successful SBT, successful spontaneous breathing trial. So within the 2 hours after extubation, we perform a diaphragm ultrasound. So we use the intercostal approach, and you can see we measure the diaphragm thickness during inspiration and expiration and inspiration. During inspiration, the diaphragm thickness increase, and we calculate the thickening fraction of the diaphragm, and we showed that, as you can see, patients who had extubation success had a higher TFDI, higher thickening fraction of the diaphragm as compared to the patient with extubation failure. And the performance of the TFDI to predict the outcome of weaning was quite good, with an area under the ROC curve of 0.73. But we also wanted to evaluate a simple index that is just asking patients if they are dyspneic after extubation. And you will see that the results are very interesting, because just simply asking the patient, of course, they have to be cooperative. And we all know that it's not always possible. But if you ask patients, you will have also the comparison that is significant. And this result here that show that patients with extubation success were much less dyspneic as compared to the patient who had extubation failure. And here again, the predictive performance of just asking for dyspnea was associated with very good predictive performances. So diaphragm dysfunction is important, certainly, but I wanted also to highlight an important message, and to show you this study published by Boris Young and Samir Jaber in Montpellier. They also evaluated the diaphragm dysfunction in a prolonged weaning patient, and they found a high proportion of patients, 80% here. But what you can see is that among the patients with diaphragm dysfunction, 44%, so let's say half of the patient, had a weaning success. So I think it's important to keep in mind that despite you may find diaphragm dysfunction in patients, it should not discourage us to start and to proceed with the weaning process and eventually with extubation, because diaphragm dysfunction is very prevalent, it's very frequent, but in some cases it should not it is not always associated, of course, with weaning failure. So now I'm going to talk about strategy, therapeutic, and to start with some curative strategies, because when we diagnose diaphragm dysfunction, it's always a big problem because we don't really know how to deal with it. And of course, we all have been aware of inspiratory muscle rehabilitation or inspiratory muscle training. And here you have a meta-analysis that was conducted by Stephanie Voroda and Johan Golliger. And they found a positive signal in favor of inspiratory muscle training. But the problem in this kind of studies, as you know, is that you compare an intervention, the inspiratory muscle training, to control. And the control group is not always very well defined. The weaning is not always protocolized. So it's quite difficult to really compare the studies. There is a lot of heterogeneity. And another problem with inspiratory muscle training is that it requires patient cooperation, so it's not always feasible. And just to finish with it, inspiratory muscle training, of course, is not specific of diaphragm dysfunction. So for this reason, we have a lot of interest in alternative strategy. And for instance, diaphragm and phrenic nerve pacing. And of course, you know that it is possible to wean off patients from the ventilator through surgical approaches that are permanent approaches with permanent devices. For instance, in patients with high spinal cord injuries or central hypoventilation. So it's surgery. And of course, this is not possible for our patient in the ICU. But these recent years, some mini invasive approaches have been developed. There are approaches that use devices easily removable. So it's really interesting for our patient in the ICU. These kind of approaches are percutaneous or transvenous or surface or peroperative. So this is something that we could consider for our patient during surgery and for post-complication, for post-thoracic surgery, or of course for our patient in the ICU as a curative strategy, but I will also mention that as a preventive strategy. So let's just have a look on this recent study published in 2020. They used percutaneous electrical phrenic nerve stimulation, and they showed, as you can see here, it's a feasibility study, so very preliminary, no clinical outcome. But as you can see, by using this kind of device, they were able to stimulate the phrenic nerves and to get a pressure that is showed here, a pressure generating by the stimulation of the phrenic nerve. So this is something interesting, but of course it's cumbersome because you have to find the good location of the nerve. It could be also painful, so it has some disadvantage, but I think it's also something interesting. And there is also another approach that is a transvenous approach. You can see here by going through the left subclavian vein, you have a close contact, close access to the left phrenic nerve that you can see here in orange, and the right phrenic nerve that you can have a look here on the right side. So through a dedicated catheter, you may have an access to both phrenic nerves, and you may be able to stimulate the phrenic nerves and to contract the diaphragm. So this is a study that we have bin conducted. It was a Rescue 2 trial. We used this catheter that you can see here. It is a single lumen catheter with electrodes on it. And we were able to stimulate the phrenic nerves and to get some contraction of the diaphragm. So the population of interest was a population with, of patients in the ICU with prolonged weaning, difficult and prolonged weaning. And I will just show you briefly some preliminary findings. First, with the maximal inspiratory pressure, that is an evaluation of the global respiratory muscle strength. And you can see that there was a progressive and significant increase in the treatment group of the MIP, so it is a very interesting signal. And when we look at the weaning outcome, there was no significant difference between the treatment group and the control group. That was a protocolized weaning, despite a higher proportion of patients in the treatment group, 82% versus 74%. But there are very promising results, and another study is ongoing, Rescue 3, that has a goal to enroll more than 200 patients. So the real discussion is really as a preventive strategy before to go to a curative strategy to try to titrate the inspiratory effort. It has been discussed previously by Laurent, and I don't want to go into detail with that, but just to mention that we could also use the phrenic nerve stimulation in this strategy, because you can see that by using here, it's a surgical device, but the concept is the same. It's a proof. It's the same. It's a proof of concept study. Here it's ships, ventilated, not paced, and here ships, ventilated and paced. And you can see that the diaphragm of the ships that was ventilated and paced had a preserved size of the respiratory muscle fibers. So it may suggest that we could also have the same in our patient to preserve a certain level of diaphragm activity and therefore to prevent from atrophy and to dysfunction. So I don't want to take more of my time. I just want to conclude and to say that we have some very promising leads for the future as a preventive approach in order to maintain a certain level of diaphragm activity that may prevent atrophy, but probably also in patients who already have the diaphragm dysfunction as a curative approach. So this is the end for me. Again, I'm very happy to be here to take any question.
Thank you so much, Martin. Very great talk. At this moment, we have no question from the chat. Probably the people is a little bit shy. So I would like to start to ask Laurent. You described 3 indexes, to monitor: P.1, POCC, and PMI. What could be the targets you would recommend, to balance, the too much or too low respiratory assistance?
Yeah, that's so. Of course, we have to say that there is no perfect index, right? So that's why it's always important to understand how it works. What are then the limitation. So P01 is the very early phase of the drop in pressure. And that's probably why it's relatively a good index of drive, even if we have patients with weak diaphragm, as described by Martin. When the diaphragm is very weak, well, probably it will impact the P01, but over a relatively large range of weakness, if I can say something like that, it still reflects well the drive. So the first interesting application of P01 is to say, well, if your P01 is very low, you can be sure that your diaphragm and your muscles are not working enough. They are just triggering the vent. And we have experimental data suggesting that using pressure support this way promote diaphragm atrophy, exactly like controlled mechanical ventilation. And this is something people do not realize, that very often the patient can trigger the ventilator, but in fact, they do not really use their diaphragm enough. So having P01 at 1 centimeter of water or below will tell you that the patient is not doing enough, and that you may stop sedation or decrease ventilation. Again, it's an index of drive. So when you want to modify the drive, you modify either the ventilation for the PCO2, either the sedation. On the opposite, the P01 can suggest that the effort is excessive, but then it depends on, is it a patient with normal strength, a healthy patient, or is it a very weak patient? So you have to interpret in the context. And maybe this is where you can say, okay, I want a more precise measurement of the effort, and the POCC is a good one. So the POCC, if you have a delta pressure more than, let's say, 15 centimeters of water, you may suspect that the patient is working hard, and you may adjust the ventilation or the sedation. So these are the type of where you can use these indexes.
Okay, Martin, you would like to add a comment?
Yes, please. No, because I like a lot the PO1, but when I do the round with the patient, sometimes we think that the patient is after the acute phase. So we start to stop or to reduce sedative. And when we do the PO1, it's very high. So what's the meaning of that? It means that the patient actually is not at the recovery phase. It is still acute. And we would like to give him some sedative or to give him something to, because it looks is really uncomfortable. So what do you think with that?
No, that's very interesting, because in patient with, so that's essentially patient with hypoxemic respiratory failure, right? So including ARDS or severe pneumonia, or this type of patient. It's very true that these patients, and we have seen that a lot with COVID, when they start to wake up, they very quickly are, let's say, working very hard, having a high drive and under-assisted. This is not the case for all patients, but very specific to this hypoxemic respiratory failure. And in these patients, the difficulty will be to control the drive, to be sure that the effort, so I would say the drive is high. The next question is the effort also high? And if you have both a high drive and high effort, I would say it is probably reasonable to try to control it, which may be very difficult. So there is one study which is not published yet by Jose Dianti in Toronto with Johan Golliger, who found that the best technique to control the drive was ECMO, which we cannot, of course, do in all patients. But they showed that the patients who were under ECMO, by using the sweep gas flow, that was the best way to control. One thing which people tend to forget is that you have two settings which may be useful, does not work in every patient. One is FiO2. So for instance, if you go from a saturation of 92 to 98, which we would suppose is still correct, some patients will decrease their drive and effort. And also the PEEP level, especially if the PEEP is helpful to decrease the driving pressure and improve the compliance, this will also reduce the effort. So this is the kind of thing you can do. You can try PEEP, you can try FiO2, you can try adjust the ventilator, and then if you don't want to go to ECMO, you may have to deal with sedation.
Thank you. There is an interesting question from the chat. Are there any electrical diaphragmatic value associated with high drive or PSIE? Is for both of you.
Okay, I will start, and I'm sure Martin will have more to say. I would say we are not sure. Really, we don't know. We think that now the electrical activity is expressed in microvolts, and we think that normal subjects have values probably around or below 10 microvolts. So if you see much higher than that, you may say, well, this is high. But we have seen, especially patients with chronic lung disease, very high values. And we are not sure what to do with that, because they may be okay. We have published on our blog one case from Thailand where the patient had like crazy values of very high EDI, and which were different from the P01 or the PMUS. So I think we need to understand better. I don't know, Martin, what.
Yeah, I think one of the problems with EDI is that there is a very high individual variability. And I know a study by Giacomo Bellani, they showed that there is a very nice correlation between EDI and the PMUSC, but the slope is very different depending on the patient. So for a given patient, EDI is useful because it may give you some information of the inspiratory effort and the level of activation of the diaphragm, but I don't think it's comparable to another patient. So I think this is a main disadvantage of EDI.
There is yeah, okay, please, Laurent.
You're right. So there are different techniques, a bit complicated, but to try to infer from the electrical activity for one given patient, what's the corresponding pressure value, PMUS value. So again, during occlusion, things like that, because it may, as Martin said, it may vary a lot across patients.
Another question, so maybe to Martin. Can we use diaphragm thickness alone as a measure of weaning prediction?
No, it doesn't work.
Okay.
Diaphragm thickness is not associated with outcome. No, the thickening fraction, yes, because it is a real surrogate of the diaphragm activation. So the change in thickness during inspiration, it's a good outcome, at least in several studies, not all, but in a lot of studies, it has been associated with outcome. But the thickness itself and expiratory thickness, I won't say it's a good marker of outcome. For winning outcome. But if there is atrophy, of course, it's a sign of severity and it's a sign of bad outcome.
And Martin, I have another question for you following up the previous one. You focused on diaphragm, but there are other respiratory muscles that can help diaphragm. So what do you think about these other muscles, their assessment, their importance during weaning failure and so on?
Yeah, no, you're absolutely right. It's a very important question, but it looks like the diaphragm is much more sensitive to disuse and unloading. I know at least 2 studies in humans. There is a paper by Sanford-Levin in 2008. Actually, they also investigated another respiratory muscle in addition to the diaphragm, and there was no atrophy on this muscle. If I am correct, it was the something like that, pectoralis muscle. And another study by a group in I don't know the country, Belvart, I think was the first author, who showed that the extra diaphragm respiratory muscle are not so sensitive to disuse. But we can use it during weaning, and for instance, we have developed ultrasound of the parasternal. This is a very easy access because the ultrasound looks much more easy than with the diaphragm. The parasternal is much more superficial, and it looks much easy to get some nice image. And we investigated the ultrasound of parasternal, and we found a correlation between the recruitment of the intercostal and the weak diaphragm. And we also showed a correlation between the thickening fraction of the parasternal and the weaning outcome.
Okay.
Maybe one point we could add for our clinician is that so the diaphragm is not the only muscle working naturally. We tend to say that all the other accessory muscles. This is not true. They are not all accessory muscle. However, there is one accessory muscle which is, I think, important for clinician, which is the sternocleidomastoid muscle, because it's a real accessory muscle. So it's used when something is wrong, is going poorly. It's easily accessible, visible, and palpable. And for instance, when you discuss when to intubate, I'm not saying this is the only sign, but this is one of the important part of the clinical exam, which can help you to say this patient is using strongly this accessory muscle, so this patient is in trouble.
Yeah, okay. It's respiratory pulses. We named that many years ago. It's your landmark paper, I think, more than 30 years ago. So there is no more question in the chat. So, and I think we are just in time, aren't we? And I think we have to close this session. And I would like to thank very much again these two top speakers for their outstanding talks. And thank you for all the participants. I hope you enjoy.
Thank you very much.
Thank you, Claude. Thank you, everybody.
Ciao.
Bye-bye.